Good afternoon, I'm Eve Baird. I'm the Associate Director of Operations for the Adult Inpatient and Urgent Care Division of LPFT. I've been asked today to speak about our experience in the division of COVID-19, what that's meant for us and our patients, and how we're moving forward from those experiences. So at the start of the pandemic, we had a number of priorities within the division. We had to respond really quickly to national and local priorities, as well as ensuring that we kept services running and accessible for individuals in crisis and individuals requiring inpatient care. We didn't have the option to not deliver services, so we had to take on board everything that was coming out nationally and work out what it meant for us and our staff and our patients in the context of still needing to deliver services. We had to make sure we'd got appropriate processes in place to minimise the risk of spreading COVID and keep our patients and our staff safe. At the same time, we needed to bring the people being cared for in our out of area beds back to local services so that private providers could be part of the national response to COVID if required. There was lots of discussions around freeing up private providers to be able to become COVID wards if that was needed. It became clear as time went on that the rate of hospital-acquired infection was far higher than community transition of the infection, and this meant that we needed to be even more focused on avoiding hospital admissions wherever possible and keeping people in hospital for the shortest time possible. What that meant for us in terms of changes to our service in response to COVID was that we had to make a lot of changes very quickly. The biggest one was around enhanced infection prevention and control methods. This included use of protective equipment, and that was really difficult. The guidance changed frequently, particularly at the start. Our division was really well supported by Jane Lord and the IPC team to interpret guidance in the context of our own service, because a lot of the guidance coming through wasn't mental health specific, and make sure that we were advising staff and patients appropriately. We had to make a number of environmental changes across our services. These included changing the function of certain areas, for example, introducing isolation rooms in case patients presented as symptomatic. And we also had to think about how we would change our use of our inpatient estate if we ended up nursing people who had confirmed cases of COVID-19. In addition to this, we had to reduce the number of beds on wards with dormitory accommodation and on one ward with limited shared space to ensure that we could facilitate effective social distancing. We had to introduce new admission and discharge procedures, and this included encouraging patients to isolate while we waited for test results once they'd been admitted or pre-discharge. This was particularly difficult on wards where we were admitting people who were struggling with their own mental health at that time and helping people to understand and comply with the guidance. We had to change visiting procedures. That was really hard for patients. We went from having no visiting to facilitating the majority of our visiting in outside spaces to try and minimise the spread of infection. And we had to change guidance around leave from our inpatient wards. So we encourage patients to use limited leave so that there was less chance of people bringing infection back onto the wards once they'd been off the wards. We looked at increased use of digital solutions. For our crisis and home treatment team, this included alternatives to face-to-face contacts, but also for our inpatient wards, we were using digital solutions to support ward rounds and MDT meetings, tribunals, hospital management hearings, and then we started to look at digital solutions to some of the Mental Health Act paperwork, so looking at the use of e-signatures rather than people having to be physically present to provide a signature. We needed to look at increased options for alternatives to admissions. The community teams worked with us on this and started to offer 7-day-a-week services, and we looked at increased opportunities for intensive home treatment. As well as this, we were looking at increased options for discharge from inpatient care. There was a trust protocol agreed that gave specific guidance around the threshold for admission and discharges to inpatient wards. We also set up at pace a step-down accommodation service in Ash Villa, which had previously been an inpatient unit. And we revised agreements with partner organisations. So we agreed changes to admission criteria for our crisis houses to ensure that we could support people to leave inpatient services as soon as they were safe and they were ready to do so. We've taken loads of learning through our COVID-19 experience so far. Our patient and carers have been impacted hugely by some of the changes we've had to make. Our patients have faced increased restrictions during their inpatient admission, and we've been really mindful of that. We've sent out patient experience questionnaires to all of the patients who have been inpatients during this time. The feedback we've had so far from the questionnaires that have been returned is that 80% of our patients felt they were provided with information around COVID-19, they did feel safe on the ward, they felt able to discuss their concerns and anxieties, and that they had enough access to fresh air whilst they were on the wards. I think it's important for us to look at that other 20% and understand what didn't work for them and what we could do better. For our crisis teams, we've also sent out patient questionnaires, and of the questionnaires returned to date, 100% stated that they were advised of how to access support in a crisis during the pandemic, which is really positive. 80% rated the advice they were given from the team as good or excellent. And one really key piece of learning for us is that the overwhelming feedback and comments were that patients preferred face-to-face contact for a variety of reasons. I think it's become clear that when someone is in a mental health crisis, they really value having someone to talk to face to face, whatever precautions we have to put in place to make sure that can happen. A number of their comments included that it was difficult to talk over the phone. They feel that more time was given if it's face to face and it feels more personal. And also people talked about feeling better to see someone when they're opening up about personal issues. I think we learned a lot through our staff experience as well. We were asking staff to go out and see patients at a time when none of us really knew what COVID could do. So when the rest of the world was in lockdown and the message was stay home and stay safe, we were asking our staff to go out and continue to offer a service to our patients in crisis and on our inpatient services. Our staff showed huge courage, bravery and commitment by stepping up and seeing the most vulnerable in our society when we needed them to the most. The messages that have come back from staff around that time is the importance of timely communication and guidance. And I think one of the key things that I've taken from that is that even if the message you're giving is we don't know, that's still a message staff want to hear because they want to know the truth. They want to know what's happening, and a real desire from our staff for consistency of approach and advice. So one of the clear messages that's come back from staff is one of the things that was most challenging was if they felt they were being given inconsistent advice. I think it's been a real challenge for me and for other members of the management team to strike the right balance between avoiding unnecessary visits to wards and teams in line with infection control guidance and providing visible leadership and opportunities for support, staff to ask questions, give feedback and us to learn from experiences. I'm not sure we've always got that right, but it's something that we've been really mindful of and we've worked hard on. In terms of service delivery, I think there's been lots of learning for us in terms of the impact of numbers of people accessing services. So early on during COVID-19, we saw a decrease in people accessing crisis services. I think as the message was stay at home and stay safe, lots of people seemed to take that on board to an extreme and perhaps not seek help when they needed it. Further down the line, we've then seen a significant increase in people accessing crisis services and a steady increase in people requiring inpatient admission. This has had an impact on our ability to safely staff services and make sure we've got the right contingency plans in place to be able to deal with the fluctuations in need that we're seeing, but also to be able to deal with the changing impact of government advice. So, for example, the impact of test and trace on our ability to staff services safely as lockdown rules have been lifted and people have had more opportunities to mix with different groups of people.
Despite how it's felt at times, COVID hasn't been the only thing happening in the inpatient and urgent care division over the last 12 months. Moving forward, we will take on learning from all of our successes and challenges over the last year. In October last year, we secured funding as part of Lincolnshire's Community Mental Health Transformation Bid to accelerate our existing plans for the transformation of our rehabilitation services. We have recruited to a community rehabilitation team that was fully staffed by the end of April 2020. The aim of the team is to support individuals with mental health rehabilitation needs in the community, where previously the only rehabilitation option in Lincolnshire was an inpatient admission. The team is actively working with over 20 patients currently in inpatient services and has an ambitious target of supporting the transition of 15 of those patients to community rehabilitation services by the end of October this year. The CQC visited our rehabilitation services in March 2020, and the teams demonstrated the high levels of compassionate care they offer our patients. We retained our overall rating of good for our inpatient rehabilitation services. We were disappointed to be rated as requires improvement for delivering effective services, but we're using the feedback from the inspection team to inform the further development of transformation plans that were already underway at the time of the inspection. This year, we're building on previous engagement events with patients, carers, staff and other stakeholders to share our learning so far and hear more about people's experiences of our current services and their ideas for the future. The next 12 months is an exciting time for mental health rehabilitation in Lincolnshire as we develop a reablement pathway within inpatient services, expand community rehabilitation services, and review and update the purpose and function of our inpatient units. Across all of our inpatient and urgent care services, we're continually reviewing guidance and procedures that were put in place in response to COVID-19. For example, we are currently reviewing our visiting policy now colder weather is coming. Over the summer, we encourage patients to meet friends and family outside whenever possible to minimise the risk of bringing COVID onto the wards. As we head into autumn and winter, we're putting processes in place to support safe visits within our inpatient units. Our teams continue to work hard to ensure care is person-centred and meets the needs of the individuals involved. The Trust is committed to maintaining bed reductions in our inpatient units until requirements regarding social distancing are no longer in place. As the Trust's commitment to eliminating inappropriate out-of-area acute placements also continues, we are mitigating the reduced number of beds available in county by opening Ash Villa as a 15-bedded female acute treatment ward. The divisional team is also working with other teams in the Trust to develop plans to eradicate dormitory accommodation across our inpatient units. Our ward teams, crisis and home treatment teams and community mental health teams will continue to work together to avoid unnecessary admissions and support safe and timely discharges from inpatient care. These teams are also working alongside other partner organisations, including the local authority and third sector providers, to ensure we have the right packages of health and social care for people as they leave hospital. Within the division, we're building on the use of digital technologies to support contact with patients and carers, but also to support integrated team working. Ward rounds and MDT meetings are now generally accessible through digital mediums as well as face-to-face. This is really important for us in Lincolnshire, given the huge geography that some of our specialist services cover. My final comment in relation to moving forward is that we can only continue to deliver safe, effective, responsive and compassionate care to the people who really need it because of the commitment and resilience of our staff teams. I've been proud to be part of LPFT's inpatient and urgent care response to COVID-19, and I'm confident that we will continue to build on our learning so far over the coming months. Thank you for listening. Any questions?